Happy Friday, everybody. Another episode, Fridays at RP. This one's gonna be a little bit interesting because although right now it's Friday, we actually had a procedure this past Monday. And so we are gonna be taking that Monday procedure and throwing it in here into this Friday episode at RP. So it's just how things roll sometimes. We have one or two procedures today. Well, I'll chat a little bit more about those in a bit. One's still up in the air for some plantar fasciitis. Not sure if she was able to get on the schedule. But our morning case is an interesting one. So when I get a chance here, I'm gonna sit down and at least talk through what I know about this patient. It's a new patient to me. And so we'll be doing our initial physical exam and eval just prior to performing their injections. So we will see. But it's time to go make some coffee, people. Let's go.
All right, it is currently Monday, but you'll be seeing this at Fridays at RP, but we had a last minute add-on for an adipose stem cell procedure. So we are just about getting finished up here. I'm gonna get sterile and we are going to get underway. So the goal of the Erector spinae plane block or hydrodissection essentially is to put fluid in between the transverse process at whatever level we're at, whether that is cervical, thoracic, or lumbar, and the basically the ventral fascia of the Erector spinae plane group. There's a few, again, this is I think the first description of this in the literature was like 2016 roughly. There's a few ones that were variants that were earlier, but it was really kind of 2016. The current understanding of it is that what it's doing is when you do that, you're getting medial spread towards the paravertebral space, which is where the dorsal root ganglion lies, where the nerve root lies. And so you are going to get some anesthesia and or analgesia, depending on the concentration and the volume you use, of everything that supplies. And so you can get, analgesia or anesthesia to the posterior portion of the spine for spinal surgery or spinal injections. But because you were also getting the dorsal root ganglion, and off that dorsal root ganglion comes your lateral and anterior branches that come and provide sensation to the anterior aspect, you're apparently also supposed to get spread there. But as I said, it's just been tough. And so, yeah, so that's kind of the current understanding of, originally they thought that the actual injectate was spreading laterally outwards, but then they did a few studies with cadavers and dye, and it doesn't seem like it's spreading all the way around here. So they think it's because you're numbing the dorsal root that you're actually getting that anterior rami, because the anterior rami and the posterior rami are right there. So that's why they think you're getting that result. So so today what we'll do on you is we'll do the erector spinae plane block on one side, and then on the other side we will do the a lateral and an anterior tap block, which is a transverse abdominis plane block.
Okay.
Did you guys come across that yesterday when you were looking into stuff?
No.
So the tap block is basically a interfascial plane block or hydrodissection, where we're going to have, on the lateral aspect, you're going to have your 3 layers of your abdominal muscles, right? External, internal, transverse abdominis, and then you're going to have the bowels, the peritoneum, all that type of stuff. The most of the anterior rami from T6 down through L1 run in the fascial plane between transverse abdominis and internal oblique. Okay. And so with that, you're going to have, the intercostal nerves of basically T6 through T11, subcostal nerve, which is your T12 intercostal nerve, then iliohypogastric and ilioinguinal nerve lie in that area as well. And so you can basically do a plane block there that is then going to numb up all of this.
Now, does that one spread, or is it, again, like more the nerves that it's affecting?
What do you mean?
Like when you're injecting it, is it spreading in that plane?
No, not really. I mean, it does have some spread, but it won't spread. Like if I do an injection here, it's not going to go to the midline, but it'll numb the nerves that provide sensation here.
So kind of the same as the erector spinae block, or the thought is similar.
Well, I mean, yes, but that's how all nerve blocks work, right? You block the sciatic nerve here, you're losing feeling down here just because that's where the nerve transmission goes. So then what we'll do is I'm going to use ropivacaine because that's probably what I would use during a procedure. And then we're going to test pinprick sensation over the areas that I'd be doing the actual extraction. And then we'll just pay attention to the time. So how long is it taking for you to lose the pinprick sensation, and how significant is that? Because ideally, if we do this as soon as the patient gets on the table, and then we finish setting up for the lipoaspiration, and then the numbing sets in over, ropivacaine is usually about 15-20 minutes. Then hopefully that's enough time that we can reduce the amount of anesthetic in the tumescent, which would preserve stem cell quality better. And if it's also more comfortable for the patient and everything like that, then that's good. The only thing that you have to be really careful of if you do this, the muscle aponeurosis of the erector, or not erector spine, sorry, of the erector sheath is very, 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 very innervated. And the reason for that is a protective mechanism for your organs, right? If something is coming at you or something is pushing on that, there's a big knee-jerk reflex to get away from that because you don't want that punctured and you don't want your vital organs injured. And so you will lose some of that sensation when you're blocking basically the nerves that are innervating the erector sheath. And so if you do this and then you go to do your lipoaspiration, you just have to be very, very cognizant that if you think you're hitting fibrotic tissue, that you double check, am I hitting fibrotic tissue? Am I actually pushing up against the aponeurosis? Because again, you don't want to pierce that. Now again, you'd have to pierce through a whole bunch of stuff to actually get in the peritoneum for a lipoaspiration, but you just don't want to potentially risk that. So
you can feel that when you're going through. You can feel the difference in the tissue.
Oh yeah.
Okay.
Yeah. It's a big difference. Okay. Any questions?
No.
Beautiful. All right, everybody. So we just finished up another Friday here at RP. So to recap our day here, so we had a patient who was coming in It was a new patient to us, but it was a referral from a local integrative cancer clinic. And this patient has what's called a liposarcoma, which is obviously a form of cancer that's going to be in the adipose tissue. This patient is, because of compression on nerves in the area of the liposarcoma, which is in the groin region, you know, just the fact that cancer is a highly inflammatory environment, the nerves in the area for him were extremely painful. Now, he had some nerve blocks in the past before, which had been helpful and gave him some lasting relief, but unfortunately they weren't able to get in to see that physician in order to have those injections done again. So patient got referred over to me in order to do basically a little bit of basically a nerve block with a few additional things in it in order to try and help calm down inflammation and pain. I've talked about this before, and this is a beautiful example of why it is so important to respect all aspects of medicine, because this is a case where, you know, we're not using, we're going to use higher dose anesthetics. We did end up using a dexamethasone, so a steroid in the injection. And the reason for that is because this is not a scenario where I'm trying to, you know, hydrodissect the nerves and free them from fascial adhesions and create long-term pain relief for this patient, because the root cause of the pain is this cancer. And we have to take the tools that we have and look and say, okay, at this stage, this tool is going to work better. And this tool is a nerve block with some steroids and a few additional things added in that I won't discuss here, but that I spoke with his oncology doctor about doing. And we added those in because we believe that there would be additional benefit for basically reducing pain. And so what we ended up doing was basically what's called a TAP block, or a transverse abdominis plane block. And we did it in technically 3 locations, but 2 on the right side, 1 for a more anterolateral tap block, and then also an anterior tap block, which is really going to target the ilioinguinal and iliohypogastric nerves. And then the other side, we did a traditional ultrasound guided anterior tap block, so ilioinguinal and iliohypogastric. And you know, within about 15-20 minutes, the patient became a new person, which was, you know, it just rocks your world when you get to see somebody suffering in so much pain, and then to go through and have some pain relief, just a little bit of that weight taken off. And within about 15-20 minutes, he had 75% improvement in his pain. Now that's going to wear off. And that's the reality of, you know, doing a nerve block and things like that, is that effect will wear off. We hope that when it comes back, it's maybe not as intense, but also if, because of the diagnosis that this patient has, if that's just something that we need to continue to repeat in order to give him, you know, 3 days of relief at a time, then to them it's worth it. And so those are kind of the things that we discussed with the patient today. Prior to that, we worked with some of the students and taught them and went through a few different blocks. One was the Erector spinae plane block, which we've talked about here before, which is a block that's going to help actually reduce sensation on the around the spine, and we're looking to add that in more, one for therapeutics, but also as a nerve block to help with our more severe spinal cases that we're doing. Also, because of this patient that we had today, reviewed with them the tap blocks and the different approaches and that type of stuff, and they got to experience what those felt like, and then a rectus sheath block. So hope you guys enjoyed this episode of Fridays at RP. I love all of you. Thank you for watching, and I hope you guys have a great weekend, a great week, a great month and year, and my heart goes out to all of you who are suffering in chronic pain. See you later.